Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
All right, guys. So I welcome one and all for this class tonight. We have a class today on a very offbeat topic. It's called Hyperemesis Gravidarum. Actually, we start the case from nausea, vomiting in pregnancy, and we'll build it up to the critical stage of hyperemesis. And we will take you through the journey of different DDs, and you see how she answers. I have tried to mentor her in such a way that the minimum to maximum that can be asked in and around this case, as I usually do. So again, we have Shreya tonight. I welcome her, and I would want her to start the case presentation on hyperemesis now. So welcome, Shreya, and you can start.
Thank you, ma'am. I'll start the case, ma'am. Presenting a case of Mrs. X, 30 years female, resident of Ramamurthy Nagar, Bangalore, housewife by occupation, educated till Diploma Civil Engineering, wife of Mr. X, doing private job belonging to upper middle class by modified Kuppuswamy classification. Then date of admission on 23rd of July 2024, last menstrual period on 3rd of May 2024, expected date of delivery is 10th of February 2025, period of gestation is 11 weeks 2 days. Obstetric score, she's a primary gravida.
Okay. Otherwise, also, guys, whenever this slide is usually mentioned by all of you, date of admission is fine. LMP, you say that LMP is 3rd May 2024 with regular cycles, making her EDD 10th of February. Remember that. Just mentioning this word with regular cycles gives us and anybody, it's a very basic point that how could you just write down her EDD like that? You still have to take her menstrual history. So you will just say with the regular cycles. Every time you ask LMP and you're calculating EDD, you remember in OPDs also, you always ask your cycles are regular, right? I mean, in whichever language, whichever way, isn't it? So whenever
Yes,
you're
ma'am.
speaking this thing, that her LMP is so and so with regular cycles, making her EDD so and so, is very basic. You should not miss this. This is for everyone because this is usually the first slide in everybody's presentation. If you miss this thing, I don't want this impression to go on your examiner's mind or heart that she's missing on very important point. Okay, so remember this like you usually do in OPDs as well. Your cycles are regular. Okay, that means this is her EDD, which makes her POG right now as 11 weeks. Otherwise, if her cycles were erratic, if she conceived on IVF, medication, and now she's come to you, IVF is also very discreet because everything goes by timing over there. But if she's not, by her own cycle, erratic cycle, just remember that none of these things will be correct in that case. Okay. Our weeks of gestation will be wrong. Our tests and everything that we'll be subjecting her to, including her NV scan and dual marker and the first trimester screening, everything will not fall into place if our weeks of gestation are wrong in the first place. Yeah, you can move forward from here. So she's a primary gravida and she's just 11 weeks 2 days. Okay. Yes.
Chief complaint, ma'am. She, primary gravida with 3 months of amenorrhea, came with complaint of 6 to 7 episodes of vomiting since 1 day. No complaint of pain abdomen or PV bleeding.
So she had the first episode of 6 to 7 vomiting since 1 day, but that is not associated with any complaint of pain abdomen and PV bleed, which is very important. And why is it important, Shreya?
Ma'am, pain abdomen is very important because, ma'am, to rule out if she is having any acute gastroenteritis or any appendicitis, cholecystitis, pancreatitis, which is making her to vomit.
This symptom alone will demarcate whether it is just simple hyperemesis or it is associated with some GI trouble or upset. Okay, should we sneak in, look in further, or we can still, delineate this, slightly mild DD. You understand there is a difference of the entire world between these two important aspects. If it's just nausea, vomiting of pregnancy, you are happy, I'm happy, everyone's happy. But if this nausea and vomiting is suddenly associated with some GI problem, like you rightly said, appendicitis, pancreatitis, gastroenteritis, any hepatitis, any other problem which is going on in the entire abdomen, then we are in for trouble because she's just in the first trimester, right? And we are looking for a very long period of probably inpatient hospitalization, MDT, everything, right? So this is a very important, it looks like a very small symptom. You've just said it's not associated with complaint of pain abdomen, but how important it actually is. And there is no episode of PV bleeding, which we usually take for all patients, which is not specifically with our patient alone. So she came with 6 to 7 episodes of vomiting only in one day. All right.
Ma'am, history of presenting illness. She was complaining of 6 to 7 episodes of vomiting since one day, not able to tolerate liquids and solids. Vomiting is more during morning and bedtime as compared to the entire day. No relief on medication. Vomit containing food particle and it is non-bile stain. She was feeling nausea from the time of conception of pregnancy associated more with the smell of food. She had 1 to 2 episodes of vomiting every day, and it has gradually increased with time to this level that she is now having 6 to 7 episodes of vomiting, that she is not able to tolerate liquids at all, and she was complaining of bloating and acidity on and off since conception.
Okay. For here, this the history of presenting illness is very important, because I'm trying to understand why your presenting history is very important, because right now my mind is understanding whether this case is critical or it is not, and which direction are we going. So over here, every symptom that has been told to us, that she's been vomiting since one day only, right? So that means she must not have that level of dehydration that we immediately have to hospitalize. But the very next thing, that she's not able to tolerate liquids and solids, is concerning. One thing which I'd like to ask you over here, you said there's no relief on medication. Do you have any idea what kind of medication did she take? Was she given it? She visited some local clinic. Was she given some injection or another oral medication? Because usually oral they'll not be able to tolerate if she's having that much vomiting. Any idea which
Uh,
medication she had?
yes, ma'am. Ma'am, because she was having nausea and vomiting since the time of conception, and she was having daily 1 to 2 episodes of vomiting. So we have given her Doxinate and MSET, ma'am,
Okay.
priorly only. But she was not able to tolerate that also.
But that means she was taking it orally only, right? Both
Yes,
these were
ma'am. She was
orally.
taking it
Right?
oral.
Now, MSET,
Yes, ma'am.
okay, tell me what is there in Doxinate, the chemical composition of Doxinate.
Yes, ma'am. Ma'am, the tablet Doxinate contain doxylamine 10 mg and pyridoxine 10 mg.
And what is there in MSET?
Ma'am, MSET contain ondansetron, ma'am, 4 mg.
Yes. Now, the thing is that one of them is a first line drug. The second line has also been given. Okay. Ondansetron is second
Yes, ma'am.
line. Okay. The first line
Yes,
is
ma'am.
all these zenes and all, chlorpromazine, promethazine, your doxylamine, everything will come under first line drug. You've even given the second line drug. And did she take MSET when she was having all these problems?
Ma'am, she was taking from the starting only, starting of the
And she
pregnancy.
took that time. Okay, all right. So that means she's gradually increasing. So there was an episode when she was having 4 or 5 vomitings also. It increased to from 1 to 2 to 4 or 5 also, correct? There was a time
Yes, ma'am.
like that.
Yes, ma'am.
Okay, what was she doing
Uh,
at that time?
Ma'am, she was not very particular in her history. She told that 1 to 2 episodes or 2 to 3 episodes of vomiting just for the whole day. And since one day only, that
It has
vomiting
increased
episodes
that
has
much.
increased.
Okay, all right. Okay,
Yes,
that
ma'am.
can also happen. All right, but look at the gestational age, everyone. Can anyone tell me from my intelligent students in the listener group? Let me see my chat group right now. I want to know what is the peak gestational age at which this, vomiting in pregnancy is at the peak. That particular gestational age where vomiting in pregnancy is at the max. Yes. So who all are there? Come on. You've got to participate, everyone. Yes. Very good, Nikita. It's a good answer. Yes. See, there's a range. Usually you should speak in a range. Examiners like that. Okay. So if you can say maybe 8 to 12 weeks or 8 to 11 weeks, that will be okay. Usually it is that time around. They say 8 to 9 to 10. This is the time at which this nausea vomiting is at the peak, and then it starts declining around 11 to 12 weeks. Our patient is somewhere around that age, but it's not a hard and fast thumb rule for everybody. But usually after 12 weeks it starts declining. Yes. So link for what, guys? How to comment? All right, comment. People are already commenting then. All right, let's see. Everybody who's there on the channel, okay, everybody who's joined in the channel, please, there is a pinned message there, guys. Just click on that message and you'll automatically enter this chat room, okay, so that you can talk to me, we can have a good discussion, and everybody is going to, enjoy it even more. See, the easy questions I'm going to put forward to both the parties. Shreya is not the only one who's presenting the case. I'm sure everybody needs to be prepared. And guys, this is why I tell you again and again that every time you participate by speaking, it's going to help you out a lot. Why is it going to help you out a lot? Is because you will have a lot of confidence during your exams when your Viva will be going on. This way in which you are, answering back, the way you are answering, the time that you are taking to process your thoughts, the way you're putting it forward in front of me, what thing you are supposed to say, what not, all these things, these filters, they'll become so much at your spinal level if you keep presenting. Every student of mine who has presented once has become so confident they want to present more and more and more. Ask any one of them. Okay, I have a list of them. I usually don't take the names again and again, but I have a list of those students who are ready to present anytime you ask them to. They're that confident. And everybody of you, all of you who are watching right now, they are my responsibility. So if 5 of them have this level of confidence and the remaining 20, 30 do not have it, it's not good. Everybody for me is equal. Many of you are now about to have your practical exam. So please just come up, present the case. It's my responsibility to coach you. Okay. So we take a rehearsal. I record the case. I give the questions to them. They practice it. Then if they want, they can present it again to me. If they're still not okay, they ask me these questions. I give them the answers, and then it's a walk in the park, and that's how your exam is going to be. Okay, so just present, right? So